Everybody, and welcome back to the channel. Today, we are tackling the topic of head trauma, a very common ED presentation based on Rosen's book of emergency medicine. Because let's face it, whether it is a drunk pedestrian, a sports player, or a grandfather who missed a step, head injuries are waiting for us almost every shift. First things first, let's talk anatomy. Starting with scalp has got five layers: skin, connective tissue, aponeurosis, loose connective tissue, and periosteum, followed by dura mater, then pia mater, and then arachnoid matter. Let's break down the big bad wolves we're chasing today: traumatic brain injury and its causes. But it's important we first understand what are the grades of traumatic brain injury and how are they classified. So we have mild, moderate, and severe based on what the person's presenting GCS is. Mild is if they have a GCS from 13 to 15. Generally, mild injuries occur in about 80% of the population. Moderate is from 9 to 12, occurring in about 10% of the population, and severe is less than 8, also occurring in 10% of the population. Now, this traumatic brain injury can be caused by skull fractures, which is caused by the direct impact to the skull. We have got linear skull fractures, which is most common, and generally it does not require any intervention. We have depressed skull fracture, where the skull gets pushed in and it has increased risk of developing seizures or infections. And then we have the basilar skull fracture, which has a described textbook sign of battle sign, raccoon eyes, CSF rhinorrhea or otorrhea. Moving on to extra and intraaxial injuries. Think of brain as a fruit. Extraaxial injury is basically injury in the peel. Intraaxial injury is injury in the fruit or the pulp. So extraaxial injury is within the skull but outside the brain tissue, and intraaxial in the brain tissue. Extraaxial injuries are epidural hemorrhage, subdural hemorrhage, or subarachnoid hemorrhage, and intraaxial are diffuse axonal injury or contusions. Starting with epidural hematomas, it basically occurs between the skull and the dura, and it's an arterial sort of a bleed because our source is middle meningeal artery. On the CT, it appears biconvex. Subdural, on the other hand, is a venous sort of a bleed because its source is the bridging vein. It occurs between the dura and the brain. It is much slower in onset, and on the CT, we will see a crescent sign. It can be acute or chronic and is more prone to be present in the elderly population. Finally, subarachnoid is blood in the sulci and cisterns is the most common CT abnormality seen after a head trauma and generally does not require any intervention if the presenting GCS of a patient is good and continues to remain good. Diffuse axonal injury, on the other hand, is caused by rotational or shearing force causing the axon of the neuron to be torn. It's not very well seen on CT and generally is best seen on the MRI, which is not very ED friendly. These patients will present almost comatose or in very, very low GCS states. Contusion is basically brain bruises, and if the contusion is on the same side of the injury, then it is called coup injury, and if it occurs on the other side, then it's called counter coup injury. So a pro tip is that when we are managing any type of traumatic brain injury, we avoid hypotension, hypoxia, hypo or hypercarbia, anemia or hyperpyrexia, because this can worsen patient outcomes. Finally, the absolutely emergent and life threatening stuff, herniation syndromes. Recognize these and call neurosurgery stat. There are three main herniation syndromes to talk about. We have uncle, central, and tonsillar. Uncle is the most common and clinically significant herniation. It presents with third cranial nerve compression. So the patient is going to have anicosuria, ptosis, and pupil non reactivity and dilation eventually. These patients will generally present with contralateral hemiparesis, which can rapidly develop to bilateral decerebrate posturing. Now, there is something very interesting that is seen in those who have uncal herniation, and that is Kernohan notch phenomena. Note how I said that these patients present with contralateral hemiparesis typically. In Kernohan notch phenomena, which is basically a false localizing signs, the same set of patients are going to present with ipsilateral ptosis and ipsilateral hemiparesis. This is something that can throw off any physician. Then we have central herniation syndrome, which manifests with low level of consciousness. The patients can have bilateral pinpoint pupils or even normal sized pupils, but the posturing that they adopt initially is decorticate posturing. Tonsillar is a third type of herniation and usually one of the most fatal ones because the brain stem here gets compressed. The patients will have flaccid quadriplegia with respiratory and then cardiorespiratory arrest and death. A quick question for people listening: write down your answer in the comment box. Pupillary asymmetry, bradycardia, and hypertension is known as a what triad? A general way of managing any and every head trauma patient starts with our ABC, in which we pay particular attention to avoid hypoxia or hypotension. We calculate these patients' GCS, which has three components. It has got eye, it has got verbal, and it has got motor component. They can score a maximum of 15 and a minimum of 3. If the GCS at any point is less than 8, then we intubate. The third principle of managing these patients is to keep their bed at 30 degrees because this has been shown to decrease ICP. We also recommend the use of osmotic agents early, drugs like mannitol, hypertonic saline, which also tends to draw the water out from the cells and decreases the ICP. If the patient is on any kind of anticoagulation, it is very important we reverse it. So if they're on warfarin, then we give them PCC and vitamin K. If they're on dabigatran, then we give them idarucizumab. And if they're on apixaban, then we give them androxet alpha. Some places also advocate for the use of seizure and its prophylactic agents, but remember that if a patient is actively seizing, then we are going to give them benzodiazepine. But if we're considering seizure prophylaxis, then we have to think about phenytoin, which is our drug of choice. Finally, the injuries on the other end of the spectrum, or mild traumatic brain injuries, something that we also called it as concussion. Mild traumatic brain injury symptoms are very wide, very generic things like headache, dizziness, decreased balance, vertigo. They can have cognitive symptoms, so decreased memory, decreased language comprehension. They can come complaining of disturbances in their sleep cycle and with increased irritability and sadness. To determine if these patients are eligible for getting a CT, we have two main rules. We have the Canadian CT head rule and we have the New Orleans criteria. You can remember either of the criteria. I'm going to stick to New Orleans, and a mnemonic that I'm going to give to remember it is called SHAVE PC. S stands for seizure, H stands for severe headache, A stands for the age more than 60, V for persistent vomiting, E for any alcohol intoxication, P for persistent anterograde amnesia that lasts more than 30 minutes, and C is if there's any clinical evidence of trauma above clavicles. If the patient scores even 1, then they go for a CT scan. And with this, we come to the end of our crash course on head trauma. If you found this useful, don't forget to like, share, and subscribe to the channel for more such content.